Hi everybody, this is Venk with Always on EM. I'm really excited to meet Alison today and she's going to talk to us about her work. Alison, thank you so much for doing this. Can you tell us a little bit about who you are and then
Yeah.
share your work with us?
So wonderful to be here. My name's Allison. I'm a fourth year medical student going into emergency medicine at Vanderbilt University, and I'm here to talk a little bit today about some of the initiatives that we've done in our pediatric ICU. So we noticed that our pediatric emergency department was really nailing getting antibiotics in quickly to critically ill kiddos, but we were having some delays in the pediatric ICU. So we wanted to take a look at exactly what was going on. So this was a retrospective review using children who were flagged by the IPSO criteria, which is a modified SIRS criteria. There's lots of literature about what exactly goes into the IPSO criteria. And basically I did manual chart review afterwards to see what cases that were flagged by IPSO were actually, potentially sepsis cases that required intervention. And then based on that, looked and saw, okay, what was the time to antibiotics in these cases and what went wrong? And in the cases that I saw delays, I went around and talked to nurses, talked to pharmacy and said, hey, what do you guys think is going on and what's keeping us from giving antibiotics to these kiddos quickly? And what a lot of the nurses identified was many of them were relatively new graduates, hadn't seen a lot of cases of sepsis, and just didn't really feel empowered to have the conversations with providers that they needed to get the access that they needed. Additionally, in kiddos who are critically ill like this, providers will slam sometimes 8, 10 medications orders in at the exact same time. And nurses sit there saying, I have 1 or 2 IVs. I have no idea what to prioritize here. So what we did is we put together a worksheet that the nurse and the provider can go to in every case where a kiddo comes into the pediatric ICU who is looking critically ill, and they can say, okay, what are our medications that we're going to order? What are our priorities for getting in? Do I want the Vanc to go in first or the metronidazole? And then they also say, okay, based on all of this, and nursing also decides what medications are compatible, and based on medication compatibility, this is how many lines I have, this is how many lines I need. An additional intervention that we were able to do is one of our pharmacists put together antibiotics that are able to be push dosed. So for example, cefepime can actually be push dosed IV over 3 to 5 minutes, even though the default is 30 minutes. So the nurse and the provider can look together and say like, okay, I only have 2 IVs, but if you're able to order cefepime in this case, I can push dose that, then we can run pressors through this line. So it really empowered nurses and providers to make team-based decisions together. So we've had a lot of good feedback just from a sort of empowerment standpoint of nurses really enjoying being able to pull this out and feel empowered to lead those conversations. We have seen a gradual decline over time. We have a spike in August. We actually only ended up having 1 case of potential sepsis in the pediatric ICU in the month of August, but overall we've had a gradual decrease. It doesn't quite meet the requirements for significance from a PDSA cycle standpoint or from a run chart based standpoint, but we're hopeful as we get more data we'll be able to continue improving. We've also rolled out a couple of other things, including a sepsis order set that defaults all of the medication orders to be stat, meaning that they have to be prepared by the pharmacy within 30 minutes. Sometimes them not defaulting to stat and being ordered wrong meant that the providers had to actually call the pharmacy, which is added time in a situation where people don't have any time. So that's what we did. It's been a really positive improvement for everyone.
Alison, this is wonderful and hopefully makes a big difference for the kids and obviously it's made a difference for the team. Do you think that it'll spill over to some improvements in the team's functioning in other clinical scenarios other than sepsis? Or?
I'm hopeful, and especially, we are pulling this out anytime a kiddo comes in critically ill who might need antibiotics. So that's cases that aren't necessarily sepsis, but people are adding on antibiotics to say, in children you have to have an incredibly high index of suspicion because sometimes septic children just don't look septic. So this is pulling out this worksheet really anytime a kiddo comes in who's critically ill. So it also applies to things like burns or, neurogenic shock, other situations. And also just any time that we can facilitate communication and working together as a team, that has a positive trickle-down effect.
Yeah. Do you think I don't know if Vanderbilt uses like Press-Ganey scores or anything like that. They have some questions that the patients and families fill out about team assessment, how well the team worked together. I wonder if you would see bumps in those as the patients and families probably perceive the team is working better as well.
Yeah, that's a great question. It's not something we've thought about looking into, but I think that's a really intriguing question.
Yeah. This is really great, Allison. Thank you so much for sharing this with us, and good luck to you and your team. Have
Thank
fun
you.
here in Vegas.
Thank you, Bank.